Ishwar sir, can you switch on your video? And Selva sir, can you switch on your video? We'll take a quick picture maybe. Is Selva here? Hey, great. Just stay back like that. Hey, great. Is George around? Great, great. I will take a quick picture and I'll share it across. Amazing. Let's go. Yes, please. Yes, please. We are done. We are done. And faculty, you are free to switch off your videos as your comfort level is. Yep. Shafaq, good luck.
Welcome, everyone, and a very a warm welcome indeed to all our audience. Good afternoon from the UK, good evening from India. I welcome you once again to this very interesting session dedicated to pediatric surgery. We have very eminent faculty from India, Professor Rasik Shah, Professor Ankur Mandalia, and from the UK, Professor Nigel Hall, and we have George Bethel with us. Also joining me today is Dana, who's one of our trainees from ALSGBI, Professor Selvasekar, the President in Standing, Dr. Kanagavel, and Professor Iswar Murthy, and indeed the President for IAGES, Professor Satish Midha. The format of today's session will be a beginning with the pediatric session from the UK faculty, followed by the presidential address, and then an address from the faculty from IAGES. I am Dr. Shafaq Sheikh. I'm a colorectal surgeon from Scotland, and I am the international rep for ALSGBI. So I have great pleasure in welcoming Professor Nigel Hall, who is the professor in the Faculty of Medicine at the University of Southampton and consultant pediatric and neonatal surgeon at Southampton Children's Hospital, having graduated from the University of Cambridge and trained at very eminent centers like Great Ormond in London, as well as in Toronto in Canada. He's going to give us an insight about foreign bodies ingestion in the pediatric population. Over to you, Professor Nigel Hall. Thank you very much.
Thank you very much for the introduction, and it's great to be here in this international seminar this afternoon. I'm going to first off introduce Mr. George Bethel, who's going to take you through a case presentation, and then we're going to have, I'll switch over and give a presentation about foreign body ingestion, particularly magnet ingestion and button battery ingestion. This is a particular problem in the pediatric age group that some of you may have the misfortune to encounter children who present. And so it's largely an educational talk rather than lots of operative videos, but I think an important and increasing problem that we see in pediatric surgery. So Mr. George Bethel's currently a clinical research fellow at the University of Southampton and Southampton Children's Hospital in our department. And he's going to take you through a case presentation to kick off the topic. Over to you, George.
Thank you, everybody, for this opportunity to speak today. So, yeah, as Professor Hall just said, I'm just going to run through a case presentation of a foreign body ingestion in a 9-year-old child that we treated fairly recently. So this was a 9-year-old girl. She was playing with some of these ball-bearing magnets, and she had one on top of her tongue and one underneath her tongue to simulate what it would be like to have a tongue piercing, which is quite a common thing we see in the UK in girls around this age. She ingested both of these magnets and presented to our emergency department shortly afterwards. When she got to us, she was completely asymptomatic. She didn't have any symptoms, and examining her abdomen was completely soft and it was non-tender, and she was previously fit and well. So we obtained an X-ray, and it showed that both of the magnets were below her diaphragm on the initial X-ray. We also did a chest X-ray too, just to check for other foreign bodies, but there's nothing on the chest, just these two magnets below the diaphragm. So we elected to admit her to our institution, which is a tertiary pediatric surgical centre, so that we could observe her and organise some serial X-rays. The reason that we admitted her for observation is, we'll talk a bit more about this over both of these two presentations, but the risk of complications, which I'm sure many know about. But yeah, multiple magnets are particularly concerning. And we want to ensure that they are passing without getting stuck in the GI tract, which may be a sign of complication. So we admitted her for observation, and we planned a further abdominal X-ray 12 hours following her previous one. This is her following X-ray, which at the time was quite reassuring. Clearly the magnets had progressed. It appears that they are together, and they're now somewhere in the right lower quadrant, right iliac fossa. We were relatively reassured that they were progressing together at this point, and we hoped that with further radiographs, they would show complete passage. We planned another X-ray around 12 hours later after this one. Here, however, we found that the magnets were in pretty much exactly the same place. And at this point, we were worried that they were stuck. They may be in separate loops of bowel, and therefore, despite her remaining to be asymptomatic, we were concerned that she would develop a complication, and we therefore planned to take her to the operating theatre. So we deemed that these had failed to progress on these two X-rays, and while she was still well and hadn't developed any complications, we thought that was the opportunity to remove these. So we planned for a laparoscopic procedure, but we also consented the parents that she may need a laparotomy also, depending on what we found. There was a bit of a delay to taking her to theatre. So it was quite late on a Friday afternoon, and there were some other more urgent emergencies that we were required to do instead. So given that our current patient that we talked about, she was well, she remained asymptomatic, we delayed this surgery until the following morning. And just before we took her to theatre, we did get another X-ray just to confirm that there was no progression, but the X-ray was very much similar to the one I've just showed you. They hadn't moved at all. So this is what we did. We set up in a fairly similar fashion to what we would do for a laparoscopic appendicectomy. We had a 12 millimeter port, just supraumbilic in the supraumbilicus. Then we had a right iliac fossa and a left iliac fossa port, and both of these were 5 mils. As soon as we got our instruments in, we were quite fortunate that it was really easy to find these magnets where they were within the bowel. This is a cecum here, and you can see that the laparoscopic instrument was immediately attracted to where the magnets were, and both of them appear to be in the cecum. We also completed a full diagnostic laparoscopy. We couldn't see any evidence of complications at this stage. There was no evidence of perforation, no evidence of necrosis at all for any part of the bowel. So this is what we did. So we then exteriorized the appendix. So we exteriorized the appendix via the right iliac fossa 5 millimeter port incision. Prior to doing this, we dissected the mesentery, the appendix mesentery, as we would in a standard fashion for an appendicectomy. We then exteriorized the appendix and opened the tip of the appendix. And at this point, we then passed the laparoscopic grasper down the appendix into the cecum, and the magnets attracted to this straight away. And we were able to withdraw the magnets, withdraw the instrument, and the magnets were attached to the end of it. So we removed the magnets and completed an appendicectomy in standard fashion and closed the base. So she had a really eventful recovery. We were able to send her home from hospital the same day. And 3 months after this, she didn't have any representations with complications of her procedure. So I think this case highlights that in certain cases, laparoscopy can be useful for removing multiple magnets. But I think it's really important to recognize that we were quite lucky here in that she presented to us early on and there weren't any complications of magnet ingestion. It would be a lot more challenging and probably not amenable to laparoscopic surgery if the magnets were outside of the cecum. It would be hard if we had to do an enterotomy in small bowel or open up the colon. If there were non-foreign bodies that were causing complications, we wouldn't have been able to find them so easily. And if we had found any complications such as fistula development or obstruction or perforation, then almost certainly we wouldn't have been able to continue as a laparoscopic case. And I think this case highlights the real importance of close monitoring of patients who swallow multiple magnets, just having a really high index of suspicion of complications developing if the magnets are not progressing. So that's the case of this girl here. I'm now going to hand you over to Professor Hall, who's going to talk more about the scale of this problem, complications that can develop, and some of the guidelines that we have to help guide our management of children who swallow foreign bodies.
George, thank you very much. Very interesting case and a nice technique there, I think, to actually get them out. So I'm going to talk a little bit more about some of these foreign bodies, and as George says, talk a bit more about the scale of the problem and some of the guidance that exists to help us manage them. Of course, they present to every hospital all over the world. So this is something that is seen not just in specialist children's centres, but also in district general hospitals where there might not be access to specialist children's surgeons or specialist pediatric gastroenterologists. So important, I think, that the wider audience have some awareness about it. And I'm going to expand this talking about magnets and also button batteries as well. We're talking about these very strong so-called rare earth magnets, often sold as executive toys or for fiddling with as sensory toys for children with neurodiversity in particular. I'm going to talk a little bit about why they pose a particular risk. It's a little bit of work about the epidemiology of them based on work we've done in the UK, and then just talk very briefly about some of the principles and guidance for management, really to try and outline the initial steps in the emergency management of them, which I hope is useful. So these are these very strong magnets. You'll have seen them advertised. They're fairly widely available. They're originally developed for the electronics industry, but they also are widely available both retail and on online marketplaces in particular. And they're really, really strong. They're anything between 5 and 30 times stronger than standard iron-based magnets, and that's part of the problem. So there's a problem because, as George said, they've got potential to damage parts of the intestinal tract if they're ingested. So single magnets that are ingested are not a problem at all. They behave as inert foreign bodies, and they may get stuck if they're particularly big or get impacted somewhere, but they're not such a problem. It's really the ingestion of multiple magnets or the ingestion of one magnet of several different time points that can cause trouble. And as you can see here, because they attract each other, it's possible for them to get into different loops of intestine and attract those loops of intestine towards each other. And when left there, they then go through a process of further attraction. They're so strong that they compress the intestinal wall between the two magnets or more than two, and they result in a number of complications related to that. So they can fistulate between loops of bowel, they can result in a perforation, at the point where they become attached to each other can act as a fulcrum round which there can be a twist and act as a episode of volvulus. And we've seen all of those complications with these magnets being ingested. So multiple magnets can cause, as I say, all these different complications. And in order to try and treat those complications in a prompt time, we need to be aware of them. We need to be aware of the signs that the magnets might be stuck and causing these complications. Because if they're left untreated, there is a risk, not just of the damage, but also of secondary effects, as I say, of perforation, sepsis, and non-survival. And there are cases reported of children who have sadly died from unrecognized complications of having multiple magnets ingested and these sort of complications. So you can see here some example x-rays of children who've got multiple magnets being ingested. They may form into a little circle, as you can see on the one on the left there, and obviously an obstructed picture. They may stand in a straight long line, and the hint is obviously there that in these radiographs you can see evidence of gastrointestinal obstruction. Here are some endoscopic views of in the stomach, and in all these cases you can see there's evidence of there being damage. So in the picture on the left, that's 3 magnets there and a long string of magnets that actually goes out of the stomach wall and the remainder of the magnets are in a loop of small bowel that's sitting around it. In the ones further on, you can see that there are magnets all in the stomach, but they've caught some of the rugae and the lining of the stomach between them, and actually also there in one of those cases have fistulated through to the small bowel as well. When we look at some operative photographs largely of intestine, you can see that there are loops of intestine stuck together. You can see evidence of perforation and fistulation between consecutive loops of bowel that obviously requires operative treatment. And we've pulled 28 magnets out of one of these children that were stuck in a long line. And in the most severe cases, I say, we've seen these act as a fulcrum around which the intestine can convolve, and obviously here you see necrotic intestine during to that process. So some of the data I'm going to show you arises from a study we did in the UK called the Magnetic Study. This was a large UK-wide epidemiological study where we tried to find out how big this problem was, really as a guide to try and inform policy and regulator in the UK, because we wanted to inform some of the regulations around how these magnets are available and how they're sold. So we did a 1-year-long epidemiological study in the UK. We asked as many hospitals as possible to take part, so these data are a minimum, and we found over 300 cases in a year. So significant numbers of children are being exposed to this sort of danger, and in over half, those children had ingested multiple magnets. The mean age was 9 years, but what we see is this interesting bimodal distribution. So these are the large things that toddlers put in their mouths, largely because they're shiny, they're attracted to them, they think they're interesting, they play with them. And also this group of teenagers who, as George showed a picture of earlier, like to experiment with fake piercings, so-called. There's definitely an increasing incidence, both reported in the UK and by groups elsewhere in the world. And here's some more examples of the sort of social media relevance. And this was particularly notable during the COVID pandemic when people were sitting at home rather unoccupied with nothing to do, and they started experimenting more like this. So in our study, we found that many of them came from toys or games. That was the largest source, that most of them were in products purchased by the parents. Many of them were actually reported by their children, which was encouraging. Sadly, some children have learned if they have mental health issues that this is a good way of getting attention and getting themselves hospitalized. And so ingestion was in fact intentional in 17% of cases. And there was some implication of social media, but not perhaps as many as we thought. 19 children had endoscopic removal of those, and that was successful in removing all of them in about half of cases. But in some of them that were felt to be in the stomach, not all of the magnets were in the stomach, and so they needed to have further surgery as well. And then 30 children overall had surgery. So quite a large number of children in this cohort having to have invasive surgical procedures. So about 10%. Some of those were undertaken minimally invasively, such as the case that George showed, but many children having to have a laparotomy to remove them, particularly those with large numbers of magnets, because as George showed, the magnet's very good at sticking to surgical instruments. And whilst it was obviously helpful in the case that was presented, often in other cases, the fact that the magnets stick to your instruments actually become a hindrance rather than a help. There's a big burden from all this, obviously, to the health service, to the child and the family. They have to come to the emergency department, they get treated, there are transfers between hospitals. And also on the right-hand side, there are large doses of radiation being given to these children. So a total of 550 X-rays and some CT scans as well, which is obviously be nice to avoid if we could. There are guidelines to help clinicians manage these, both in the emergency department and where there might not be specialist children's services around to guide them, produced by the Royal College of Emergency Medicine is this particular one, and both European, North American and other national bodies have all got guidance. So I would encourage everyone to have some sort of familiarity with these. And I've put this QR code up here if people wanted to take a quick screenshot of it to a link of the ESPGHAN set of guidance published in 2023. Just a couple of quick pitfalls to talk about. If you think there's a single magnet, as you might expect here, most of the guidelines recommend also taking a lateral view, because it is possible to have two magnets sitting one on top of each other, and you could be fooled into thinking that there's only one magnet when there's actually two, and the management of those is, as I've showed you, completely different. So in summary, single magnets, essentially you can leave alone so long as the child is asymptomatic, and also so long as there's no other metallic foreign body ingested as well. But the multiple magnets that I talked about, if they're symptomatic at presentation, that we would recommend removal. Asymptomatic, some people would recommend removing those in the stomach. I think that depends a bit on your environment and where you are and the services available. If they're definitely all in the stomach, they can probably be left alone if the child is well and monitored through the GI tract. If they're asymptomatic and beyond the stomach, then further serial radiology. There's some discussion about the optimal timing of that to monitor progression. And what you're trying to do is identify magnets that don't progress through the GI tract on serial x-rays, because that's a marker that they could have got stuck between consecutive loops of bowel. And if you find evidence that they stop progressing on x-rays, then we would recommend surgical removal. And we probably need a minimum of 3 x-rays in all cases to determine really if they're progressing or not. Because as shown here, it can be really quite difficult to see if these are definitely progressing or not. And actually, this was a child who had a 4th x-ray following this and was confirmed to not be progressing. But you could be led to believe that actually these were moving, but these were just actually in loops of small bowel, and the whole loops of small bowel were obviously moving around the abdominal cavity. So just quickly moving on to talk about button batteries. These are these flat, or otherwise known as disc batteries, that exist. And the problem with these is that they can cause contact when they make a circuit between 2 loops of mucosa. So they're a particular problem if they get lodged in the esophagus. And you can see here, there's been a number of experimental studies done putting these batteries onto pieces of meat or explanted animal tissue in vitro, showing that the damage is due to the electrical current that gets set up. There are hydroxide ions produced that result in the damage and cause coagulative tissue necrosis of this, and can cause, ultimately, if they left their full thickness, necrosis and perforation of the lumen. And this can happen really very quickly. So within sort of, half an hour, definitely within 2 hours, you can have significant damage. So a group in the UK also have done a similar study to what we did with magnets with these button batteries, a year-long epidemiological study from the UK run by the British Pediatric Surveillance Unit, which is part of the Royal College of Paediatrics and Child Health. And they found 416 battery ingestions during this period. And again, interesting, most of those came from toys, but some of them parents had just left lying around, not aware of the dangers that they posed. Important to note that they still pose a danger even when they're not strong enough to power whatever device it is that you have it in. And similar to what we found in the magnet study, almost a bimodal distribution as well, of people who were curious about these, particularly toddlers, just obviously like putting things in their mouth for sensory reasons. They also went endoscopic removal if they're in the esophagus or the stomach. And there were 8 children in that series over a year who had abdominal or thoracic surgery to remove them. And 20% of the children in that study had some form of injury from their magnet. And that was either in the form of a mucosal burn, they could be bleeding if they're rode deep into the blood vessels. And 8 children had esophageal perforation or subsequent esophageal stricture that required treatment. And again, just to report in the literature, there are obviously cases where these have been sadly contributed to death. So all these children came to the emergency department. 56 required surgery, and they again had a lot of radiation used in their management, as you can see on the right hand side there. So the real issue here is this is an emergency. Any child who's ingested a button battery should be taken to the emergency department urgently for some radiology, because the damage here occurs really quickly. And of course, you don't know at the point the child has swallowed it, whether it's become stuck in the esophagus or has gone through into the stomach. So the guidance recommendation is, obviously, if you have a child who's swallowed one of these, there's some evidence that giving some honey for the child to swallow can coat the battery and help reduce the extent of injury. That shouldn't delay subsequent treatment, but certainly that is a useful first aid sort of measure to do. On the radiology, just to note, it's really important not to confuse these with a coin. Obviously, the coin is less urgent, but on the X-ray here, you can see you could easily think that's a coin. But there's this thing called a halo sign where you can just about see an inner circle. I hope that projects on that X-ray. That confirms that is a button battery, not a coin. And if you take a lateral X-ray, you can see there's almost a two-layered bilaminar approach. That's the anode and the cathode of these button batteries. So they really just need to be taken out straight away, particularly if then in the esophagus or up in the pharynx and the larynx. And it doesn't really matter who does that, and the emphasis on the individual hospitals to try and develop a pathway for their own services to remove that. Many hospitals, I say, don't have specialist children's surgeons, but most hospitals have some ENT specialists and may be able to help with that. There's some evidence to suggest that when you've taken it out, if you apply acetic acid, you can help limit some of the ongoing damage, because the damage to the mucosa seems to continue even after the battery is removed. And that's a really important point. And then the recommendation is we place a nasogastric tube under endoscopic guidance if you can safely get it through. And then if you're not already in a specialist center, please do transfer then. But there is a real time pressure to get these out as soon as possible. And they really should be taken out locally at the hospital they present to, rather than being transferred to a specialist center, because that inevitably causes a time delay. So here's an example of some of the injury you can see. So this was a button battery taken out of the esophagus, and you can see the coagulative necrosis that's been taken away. The battery on the right-hand side that's removed has started to disintegrate in the alkali environment that is created by the electrical current. And you can see really quite significant injury there that results in really quite a short space of time. As I said, the injury does seem to continue on after the magnet has been removed. And so if there is significant mucosal injury, the guidance is that these children continue to be monitored. We would recommend some cross-sectional imaging to look for evidence of inflammation outside of the esophagus soon after presentation, and also an idea of in which direction that inflammation is heading, because the complications that are most life-threatening relate to the involvement of local adjacent structures, including blood vessels. So there are case reports of aortoesophageal fistulas forming from these, and also infections in the pre-spinal space and also into the disc space as well. So we tend to keep these children in hospital who've got significant injury for anything up to a couple of weeks, which is the time at which the longest that such complications have been reported. For a few special situations, if you've got a magnet and a button battery, obviously, that's a particular problem. There's a few cases of cases being where there's a consecutive things in the esophagus and the trachea. That's obviously particularly challenging. And I mentioned mental health earlier, but a small proportion of children have learned how to maximize the chance of harm for these. And they obviously need psychiatric support as well as just the surgical support from people like us. So just in terms of a public health messaging, we need to be aware of these and be able to act promptly to reduce the risk of complications, but also I think have a role in trying to increase awareness of these problems amongst our children and families, and also, if we can, to influence policymakers. So just to finish, a few take-home messages. The button battery ingestion is an emergency. There are some things that you can do that may help, but the really important message is not to delay removal, and to note that injury continues after the removal's been there. So do refer to the specialist centers. And the awareness of what multiple magnet ingestions can do is really important. And just a role for us, I think, in lobbying policymakers to try and result in improved regulations around the packaging of products containing button batteries and magnets, and warnings at the point of sale that many countries have regulations around already, but unfortunately aren't well enforced. Very grateful for the opportunity to speak to you here this afternoon in the UK time. And thank you for the invitation. I'm very happy to take any questions as well. Thank you.
Thank you, Professor Hall. I think, very insightful and very detailed outline of the problem. And, there seem to be very seemingly innocent pieces of entertainment for the children, but they can lead to a series of events that can quite easily turn into quite a big saga over there. There is a question from the audience, and that kind of ties in with the question I would like to ask you as well. And I mean, the specific question from Dr. Altaf Bhatt is, if there's no complaint from the child after foreign body ingestion and the foreign body is progressing, must we wait and watch? And I would like to kind of repackage this and say, you know, especially in cases where we don't really know what the child has ingested, because often parents can be oblivious to what's happened, and it's just a guess that the child probably has ingested something. So how do we figure out, you know, whether there is actually a button battery in there, and whether, you know, we need to act quickly, or is there time to just wait and watch?
Thank you for that question. Yeah, very important. I think the if there's any suspicion of magnet or button battery ingestion, I think the key is to get an X-ray early. They've got fairly classical signs and appearances on X-rays, and I think we should also have a very low index of suspicion based on the appearance that it could be a magnet or a button battery. I showed you that specific sign that makes it distinguishable from a coin, which is obviously important. But I think if there's any doubt that it's a button battery that's been ingested and is in the esophagus, then we should be continuing our line of investigation until we can prove that it's not. If you've got the foreign body below the diaphragm and the child is asymptomatic and the foreign body is progressing on a series of X-rays, clearly progressing over a period of days, then equally I think it is okay to discharge that child, because the chance of causing harm is exceedingly low, and we don't want to continue to expose young children to unnecessary radiation if it's not of benefit.
Thank you very much for that. And in conjunction with that, there's another question from a Dr. Gatnaker asking for insights on pediatric endoscopy, especially in the 1 to 5 year age group. You know, do we actually wait and watch, or do we just go and fetch it out from the stomach? I think the age group is a bit of a sensitive one there, isn't it?
Yeah, exactly. I think doing endoscopy in young children obviously is a specialist skill. It requires general anesthesia, and so isn't therefore possible to undertake in all centres for certain. So I think it's important to therefore understand exactly what the aims of treatment are and what we're trying to achieve. And actually, if you've got an inert foreign body in the stomach in a child who's asymptomatic, I think there's not necessarily a good indication to take anything out at all. And so long as there's facility for the child to be monitored, be it by their parents if necessary, or if necessary in hospital, then I don't think there's a desperate urgency to retrieve something that's definitely in the stomach below the diaphragm.
Thank you very much. And then there is a question for George from Dr. Mugo. Firstly, a compliment, ingenious technique to extract the magnets. Why do you think did the magnets get stuck at the widest part of the bowel?
Yeah, I mean, this is a bit of a strange one. They obviously came out quite easily when we put the grasper in there. I guess, you know, the other side of the argument is, could we have waited longer? And could we have been braver and thought, wow, yeah, they were swallowed together, will they just pass on their own? Yeah, we did discuss this fully with the parents, and it was that kind of that balance between, you know, we've got a well child now. Hopefully, if we do a procedure now, we've got relatively high chance of a successful laparoscopic procedure where we remove these. But it may be, you know, if we wait longer, they're passed on their own. So I'm afraid I can't answer that question directly. I can only say, you know, when we were actually making decisions about what to do, it was just a balance of risk and full discussion with the parents about what the risk and benefits look like.
That's often the case in the clinical world, isn't it? It's just you go pragmatically and take your decisions. And this sort of brings us towards the end of the final question. There is the first session, sorry. There is a final question about the incidence of magnetic ingestion. I think worldwide, I don't think anybody would have looked into it, but the UK incidence, Prof. Hall, you've outlined with the magnetic study. Is there any data on a global level or not really?
Not that I know of from a sort of truly epidemiological basis, no. There are very few population-based studies that have looked at this. And as I say, most of them, even ours, I acknowledge is probably an underestimate of that, because we can't be certain that absolutely every child who presented during the time period was there. So I think it's difficult to tell, but it is a growing problem. And I think it's important, therefore, that people who work in hospitals where children come to the emergency department have an awareness of the problems that can be caused and their initial, certainly emergency management of them.
Fantastic. So with this, we wrap up this first session. There are a couple more questions popping up, but I think we can take them all together at the end, because we do have both the presidents with us on the session just now, and it's a great honor for me to invite Professor Tan Arulampalam to give us an address on behalf of ALSGBI. Thank you, Professor Tan.
Hello. Clearly, the educational content, thank you, Shafak, and everyone who's taking part and organised this. Clearly, the educational content of what's happening is far more important than you listening to me. But what I want to say is I want to just put my full backing to this programme, because not only are we talking about really important problems, discussing cases, but we form a community where we can ask each other for help. And I think that's what the collaboration between IAGES and ALSGBI has, for me, I think that's one of the most important things. We've developed new friendships that have absolutely no physical boundaries. And the energy of the young folk getting involved is also great to see. And I have to shout out for Dana, who has done an immense amount of work for this. So thank you very much for IAGES. Thank you very much to you, Shafak, for taking this on. And actually, webinars are often very dry, as I said on Thursday, but this is fascinating and really adds to everything that we are about. Our core business is education. So thank you very much. And thank you for the Executive Board of IAGES for collaborating so beautifully with us. I must say that our annual scientific meeting is on the 3rd and 4th of November at London Stansted Airport. We want to just make sure that all of you are aware of that. You're warmly invited and welcome to join us. It's going to be a very, very interesting and educationally stimulating time, but also where we can meet face to face. So thank you very much, all of you. Thank you, Shafak. I'll hand it back to you.
Thank you very much. I think it's a lot of hard work in the background with, both sides of the team. And we're also joined by Graham and Altaf, who's our Director of Education. Thank you very much for coming online. I will hand over now to Dr. Kanagavel for the presidential address from the IAGES side. Thank you, Kanagavel.
Thank you, Shafak. Thank you, Professor Tan and other speakers for making evening very worthwhile academically. And friends, ladies and gentlemen, now I have the honor of calling upon our president, Professor Satish Mehta, to give a few words and then we can take this further. Dr. Mehta, please.
Good afternoon and good evening, everybody. Professor Tan and all those present in this webinar, I bring greetings from IAGES, one of the leading organizations of minimal invasive surgeons and endoscopists. I think we had good discussion on the first part and hope the other two topics being presented by Indian speakers will also be attractive and draw attention. We have been going nicely with the topics. This time, this was a bit topic away from the traditional topics which we discussed. So initially there were hiccups, but I think the topics chosen were of quite interest. And I, being surgeon as well as endoscopist, I also come across many of these problems. And we don't have the data, but a lot of patients come to us with batteries, because nowadays many of these appliances have batteries and we don't have much regulations here, maybe how to dispose them and all this. So this is common problem in India also. And the magnet, the property which is now being utilized by endoscopists to form the fistulas. So they can do the harm also. So I congratulate the whole team for their efforts, regular efforts for holding these webinars. We are looking forward to meet you all in the first week of November. At the same time, I invite you for our two events. One of them is, of course, quite nearby, our midterm conference in last week of October, and definitely a big contingent we look forward in the month of February 2026 in Mumbai. Thank you all. So wish you all the best for the rest of the proceedings.
Thank you, President. And I'm in fact very, very happy to see almost 1,800 surgeons across the globe have joined today's meeting. Very happy to share. And this is the platform document from the DocPlexus, and we have other avenues of watching the program as well from Facebook. I sincerely appreciate the good efforts taken by both the teams for making this a possibility. Friends, I will not take much of your time, and I have the pleasure of sharing a couple of very important information. This is the annual scientific meeting of the ALSGBI, which is happening the first week of November. Those are yet to register should block their dates and kindly register themselves for the program and make sure you are available for the event. And also, we are very glad to announce the upcoming ALSGBI combined meeting on the month of November. So we have the important body of anastomotic leak in colorectal surgery, and we have very eminent team from Bart's Hospital from your side, and we have a couple of very eminent surgical oncology team and advanced laparoscopic surgery team from our side contributing. We look forward for this important meeting. And friends, we have very exciting events happening on our side. Course come meeting at the mid-IAGES in the late week of October. Those who can join are welcome to join. And of course, this is one of the biggest event regionally. Like we are doing a combined work with the ELSA, and this is going to be in the second week of February 2026. So, like without much ado, now I hand over to the proceedings to Dr. Ishmurthy, our past president and trustee for the IAGES, and again a very eminent endoscopist by himself. And he is authored multiple books, and we are looking forward one more textbook of endoscopy. New edition is going to come up over this month. And he has individually trained more than 3,000 surgeons on endoscopy and continues to train surgeons on endoscopy, endotherapy, and colonoscopy. So now I request Dr. Ishwar sir to take over the proceedings and take up the rest of the event. We have Professor Rasiksha already here. Thank you, President.
Thank you.
Over to you, Ishwar.
Thank you, Kanagavel. Thank you, all my viewers. It's really nice to hear both Professor Hall and Dr. George, the British innings on foreign body, the management of which is close to my heart. We'll discuss a few salient points at the end of the day, but now I have a pleasure of introducing both our Indian batsmen who is going to play the Indian innings on pediatric surgical front. Initially, one of the eminent pediatric surgeon, Professor Rasiklal is actually now currently practicing as a full-time pediatric surgeon at SRCC Children's Hospital in Haji in Mumbai. And as you all know, he has extensively trained in the art and science of pediatric surgery in Tennessee, USA. After his fellowship, he came back to India to teach and train lots of pediatric surgeons. And also he is now currently also the director of the training program in CMAST Mumbai, one of the very prominent training center. And he is fondly remembered as a father of pediatric laparoscopic surgery. I think he is going to talk to us on the challenging topic of how a minimal access surgeon could manage malrotation of the gut. Because even as an adult, we have seen a couple of cases where they are present a bit late, and we have a problem, not only diagnosis, and when you go in and see something which you are not used to handle, like a lad's band, we struggle through by watching some of his videos also. So we like to see him face to face and interesting to listen to him. Over to you, sir. Asik Lal, sir.
Thank you, Ishwar Murthy, for a very nice introduction. And it is going to be, I mean, the topic was selected just because that it can be missed during pediatric age group, and it can be seen at any age. And when it is seen at any age, sometimes, general surgeon will not know what is exactly happening. Can you see my slides?
Yeah, it's very nice.
Okay, so let's start. Okay, so this is the hospital where I work today, SRCC Children's Hospital, and greetings from hospital as well as from Mumbai to all of you. So there is a physiological herniation when the child is in the womb. At around 5 to 6 weeks, it comes out and then it goes back. And there is a standard way it happens. And this is actually incidence of 1 in 6,000 live births, and there is no sex or race predilection. Late described somewhere in 1936, the procedure, and that procedure remains same, except that we do it today laparoscopically. We personally, I have done 45 cases since 2003, and I done a couple of them when I was in Memphis in 1996. Yeah. So the title got exchanged. So this is the physiological herniation which happens at around 5 to 6 weeks of gestational life. And when the bowel returns back into the abdomen, there is a rotation of the bowel. So DJ flexor, which is on the top or superiorly, it rotates by 270 degree and comes to the left of the superior mesenteric vessels, and ileocecal region, which is inferiorly of the superior mesenteric vessels, it rotates by 270 degree and comes to the right upper quadrant, and then it migrates down another 90 degree and fixes in the right iliac fossa. So this is normal rotation. Anything which is not this is known as a mild rotation. So we will discuss about that further. Now, clinical manifestations is basically vomiting. Most of them will present in the 75% will present in first month of the life, 90% by in first year, and the remaining will come after 10 years, and some of them will reach the adult age also at 20, 30, 40. Few of the patient where a few of my adult general surgeons had this patient, and then we did it together. So sometimes it is asymptomatic and detected incidentally. Acute presentation happens with bilious vomiting, and sometimes it is recurrent bilious vomiting with scaphoid abdomen. So if anything of this is there in a child, one has to suspect possibility of malrotation and then act. If you don't act in time, there will be formation of volvulus, where there will be excessive crying due to abdominal pain, hematemesis, bleeding PR can happen. Abdomen will be tender, erythematous. There will be hypovolemia and metabolic acidosis. This is late, and we don't want to miss malrotation so that the child gets into this problem. So try and avoid that as far as possible. So even sometimes, or rather it is advocated, even asymptomatic malrotation should be operated. Now the diagnosis is by barium. Normally what happens is normally the DJ flexor is on the left of the vertebral column and at the level of pylorus. So if anything is against that, will be malrotation. Double bubble sign, paucity of gas distally, jejunal loops on right side, no colonic shadow in right iliac fossa, they are all suggestive of malrotation. Features of complications will be dilated bowel loops, air fluid levels, and pneumoperitoneum. So this is late sign, and we don't want to wait till that. On sonography, there is going to be reversal of SMA-SMV relation. So normally artery is on the left and vein is on the right. If there is a reversal, then it is suggestive of malrotation. And sometimes you will get whirlpool sign like this on sonography, which is suggestive of volvulus. On CT also, all these findings are there, and there is aplasia of uncinate process, and you can see over here how the volvulus will look. So once you diagnose it, then the treatment is surgery. Pre-op preparation is nothing particular, but in older child, we may do upper GI endoscopy to rule out any intraluminal obstruction, because when we do laparoscopically, we can miss that and the patient can have persistent problem. This is not very common, but it can happen in less than 2, 3, 4% of the patient, and sometimes it may need resurgery. Otherwise, routine investigations, whatever is required, one can do for the fitness. Position of patient and OT setup. So we keep the child supine like this on the OT table. Surgeon stands on the left side. The camera person is below the surgeon. So something like lap call is the position. Monitor right side head end and head high right side up. So this is generally we keep, or occasionally one can go to the foot end and split the leg and stand in between, and monitor can come on the center if it is a hanging monitor. Now position of the ports. So generally we put umbilical port, which is 30 for the 30-degree telescope, and 2 or 3 working ports for the right midclavicular line. This will be for my left hand, which is just below the umbilicus or at the level of umbilicus. This is left midclavicular line for the right hand of the surgeon. And if needed, I put in a subcostal area somewhere in the anterior axillary line. This is for the retraction of the colon to open up. So something like this. This is what I use. Some of my colleagues puts the ports little lower down so they can have a bird's eye view or panoramic view, but I don't find any reason to do that, and I don't do it. So this is very important. The principles of the surgery, which we were doing in open surgery, today we do it laparoscopically. So division of all bands which are crossing the duodenum, originating on colon, going over to the duodenum and into the retroperitoneum. And then you want to straighten the DJ flexor. And at the end, one has to make sure the mesentery is widened enough. If you don't do that, then the recurrence of volvulus can happen. And we had in the initial phase one patient who came back with, or rather in post-op period, developed volvulus. And since then, we make sure that it is widened adequately. What I say is a 50% of the abdominal width, or about 4 to 5 centimeter. And most of the time you will see the pulsations of superior mesenteric vessels, and that will be the point I'll say enough has been done. Yeah, and then you make sure that you divide all the bands even in the small bowel. You can't leave that, otherwise the child can develop or patient can develop localized volvulus of the small bowel. And then you look on the posterior part of the duodenum and release that also. At the end, we do appendicectomy, which is controversial. One may not do it, but we like to do it because if the child develops appendicitis after this, usually it is missed and they come with complications, and in them to do appendicectomy is very painful. So this is the video which I am going to show. Here, this is a newborn child about 10 days old who came with the bilious vomiting, and we just did an X-ray and took the patient for surgery. We did not do any more investigations because it was classical volvulus scaphoid abdomen bilious vomiting. Now, once you do that, what you see is the cecum in the upper abdomen, which we don't normally see. So the cecum you can see here, and these are the bands which are going into the retroperitoneum crossing the duodenum. So all these bands are known as Ladd's band, and you keep on releasing. So this is that will be the retroperitoneum where you will find the kidney. This is 3 millimeter instruments which are 20 centimeter long, and 5 millimeter 30-degree scope. This is what we are using. So you keep on, and this is what we like in newborns is the hook cautery, because it's very precise. I'm not worried whether I will damage anything, any important structure. So you keep on releasing these bands which are going from colon, ascending colon, cecum into the retroperitoneum. Our aim is to widen the mesentery, and when at the end, this colon, cecum and colon will go on to the left side of the abdomen. So all this you continue. So important point in using hook cautery is your left hand. Your left hand, if it gives more traction, you finish the surgery faster. So the idea is to learn using your left hand correctly. So all these bands we will keep on releasing. The left hand is holding the bowel grasper, which is fenestrated, and it's a beautiful instrument made by Karl Storz, and we love it in most of our surgery where we need to handle the bowel. That is the instrument I'll use it. So we continue using that division of the bands. You can see nicely, so nicely these bands are there, and always hook should point towards the sky. Now you can see the duodenum has come into the view. That is the pancreas. So we just continue doing this till you get, the first thing is you want to divide this so that you have exposure of the duodenum. And then we will see how the rest of the thing is done. Because this child has volvulus also. If we don't operate in time, this volvulus can become the bowel, the entire small bowel can become gangrenous, and then it is difficult to survive such a child. You know, they will need long-term TPN and small bowel transplant and all that. So it is, which is not easily available in most of the part of the world. So all these bands are divided. That's the duodenum, which is going to become straight. We are still, we have not seen the DJ flexor, which is somewhere there. Yeah, it is there. So you can see that's the DJ flexor area. So now this bowel, which has undergone volvulus, we will take it out so that the volvulus gets corrected. So you keep on doing that till the entire small bowel comes onto the right side of the abdomen. What it will do along with that, it will correct the volvulus. And this two bowel graspers are very good to handle this part of the surgery. So we will continue doing that, and at the end you will see that all small bowel is on the right side. Ileocecal region is in the epigastric area. You make sure that the lie is like this, the volvulus is corrected now. And now you will see this cecum and appendix, ascending colon, and whatever adhesions are left now, they still needs to be released so that the base of the mesentery is widened. If you don't do that, then the chances of volvulus are still there. So you will see now how we will divide that. And this hook cautery is a beautiful instrument, and we will continue using that. Many times people think that harmonic scalpel or ultrasonic or bipolar vessel sealing device may be good, but they are not good for the newborns because we have limited space and their blades are too large. Hook is the best instrument where only few millimeter of the instrument, which is the tip, metal tip, is exposed, so we are not worried. So we'll continue releasing this fiber so that the left side, or rather the ascending colon and cecum, goes onto the left side of the abdomen. And as we go further, you will see how well we are widening the mesentery. All the adhesion or all these bands are divided well. You have to be careful that you don't damage the vessels. which are just underneath. So that's the pancreas in the center, that's the duodenum, and all these bands one has to release. So there are some more bands which are distal. So we will continue releasing that so that the base of mesentery is widened. So all these 3-4 steps, what we call, they are very important, and I will speak probably 10 times, 15 times before my talk is over. So widening of mesentery, straightening of DJ flexor, they are all important steps in the correction of malrotation, because you don't want to get into problem of recurrence of volvulus, because when there is a recurrence, many times it is detected late and the bowel can die. So we continue doing that. There is 2 more minutes of the video, and then we will discuss about other aspects. So so this is still closer. So we need to, sorry. I'll have to jump. So that is the part from where we missed it. So you keep on releasing that. And as I told you, it is all this is possible because of the hook. Other instruments will not work here very easily. Let the video run, because if I try to go further, then it will go to the next slide. Yeah, so you keep on releasing that, and at some point we will see that everything is separated, and the pancreas is exposed well, superior mesenteric vessels pulsations are seen. This surgery takes about 1 hour or 1 hour 15 minutes. And this is almost an entire video. You can say even the editing part was less. So now you can see the base of the mesentery is widened. The cecum appendix has gone completely on left side. You can see nicely the pulsations. At some point you will see the pulsations of superior mesenteric vessels. Yeah, you can see over here. You can see nicely pulsations. And some bands, if they are left, you can take care of them. And appendix is devascularized. Generally, I just take it out from one of the port, put a ligature and take out the appendix. Alternatively, you can put 2 endoloops, divide, and then take it out, the appendix. So one of the port, it is taken out. You can see that's the pulsations of the vessels, and adequate job has been done. So let's go further. So in some patients, you see variations. In older child, you will see the adhesions are very thick. Only Leitz bands originating from pancreatic area going over the retroperitoneum, causing the duodenal obstruction. Bands similar to Leitz bands affecting localized segments. So sometimes it is localized like this. And sometimes like this, there are only bands. The mesentery is widened enough, but there are only bands. There are no, it's not going from cecum and ascending colon. So these are a couple of variations we have seen over the years. This is what we see in the older child. In older child, the adhesions are more thick, and in them I may use harmonic scalpel also, or bipolar vessel sealing device, whatever it takes. So in older child, we find the adhesions which are, the bands which are much thicker and vascular. And in them, one can do it with hook, but it is safer or easier to do with this instrument. Post-operatively, we start feeding after 6 hours, and usually full feeds on first post-op day or second post-op day, and they are ready for discharge. Generally, we just give paracetamol for analgesia. Complications, we have seen roughly 45 patients between 2003 and 2025. We have not converted any to open surgery. We had 6 redo laparoscopic surgery done by others. 5 completed laparoscopically, and 1 we had to convert to open. 4 recurrence of malrotation with volvulus primary surgery was open. So out of these 6 patients, that 4 had surgery for this, and 1 child underwent appendicectomy by one of the general surgeon, and then he showed me the video, and I said this is malrotation, and we went ahead and did surgery for malrotation. 1 patient had jejunal stricturoplasty and malrotation was missed, so we had to go in. The child had continued to have pain, and we went in and corrected that. So out of our 45 patients, we had 4 patients where there was some complication which needed resurgery. Of that, 1 patient had recurrence of volvulus, which I said in our initial phase, and 2 patients had adhesive obstruction. 1 had missed duodenal stenosis, which we needed to reoperate. This is one of the publication where there is a meta-analysis of 49 publication, 1,003 patients, where 74% open surgery was carried out, and only 26% had laparoscopy surgery. 1 surgery, open surgery, were younger than laparoscopic surgery age group. Conversion in laparoscopy was 25%. So if you know the correct steps, you can avoid the conversion. We could start feeding early in laparoscopy group, so 1.5 plus or minus 0.3 days. In open, the feeding was started much later. So hospitalization in laparoscopy group was about 6 days, and in open group was about 11 days. Open surgery had higher complication rate of 21% than laparoscopy group. So if we persist on this, we can avoid this gap of complications. We should be, if we do laparoscopy, then we can reduce this complication rate. Post-op volvulus more common in laparoscopy group as compared to open group. So mainly it is adhesive obstruction which we get after. So I am associated with IMUS, which was earlier CMUS, and I am really thankful or obliged of Dr. Temtem Udwadia, who was instrumental in taking me as a course director, which helped me in developing my expertise as well as. Thank you for the opportunity to be part of IAGES ALSGBI webinar. Thank you. If there are any questions, I'll be happy to take.
Thank you, Professor Rasiklal Shah. It was really nice, elegant presentation with an excellent video, which showed all the steps from the beginning to the end. But in your experience, I see that you had no conversion, and there is very little, if at all, a complication. But as a beginner, as a pediatric surgeon, what is the learning curve for a young pediatric surgeon? How he can circumvent? Either he has to do first few cases open, understand exactly what has to be done, then take them through, or is there any virtual model available you go and teach? Whether any simulation available for such common procedures? How do you go about training your youngsters in this laparoscopic release of large band?
I think basically one needs to have a good mentor and who teaches them how to do it. And if they know it, I don't think they will have much problem. Of course, if at any point, if it doesn't look safe, or if we are not progressing more than 5 to 10 minutes, we are stuck, then it is best to convert. So conversion, we don't call it is a complication anyway. So if it is conversion, it is okay in the beginning of the phase, because they, I mean, there is definite higher conversion rate across the world. I am fortunate enough to bypass that, but not everybody can do it. So that is all right if there is a conversion. I can tell you only one thing, that there are quite a few pediatric surgeons who have called me up and asked about tips and tricks how to do it. And they discuss with me and they call me back after a day or two that they could complete it laparoscopically, which they were not able to do it earlier. So I think if they discuss with the mentor, then they should be able to complete. Though we do not have any models for doing this surgery or simulator.
Thank you. Thank you.
Yeah.
Thank you, sir, having joined. It's IAGES, as you know. This is a institution started by Professor Tekman Udwadia and more than 25 years ago, and it's very, very nice to hear that the very same institution where he established the training and you are doing a noble service of training the young pediatric surgeons. It's very heartening to hear that. Please continue your service to the humanity. Thank you.
So there is one query which I think I should take it, how do you differentiate between the thin layers of mesentery during widening and dissection in laparoscopic view, considering very thin mesentery in neonates? So here, widening part is generally not difficult to know which part is the mesentery. But when I'm releasing the bands which are crossing the duodenum, sometimes there is a confusion whether it is mesentery is this side or that side. So when I did open 25 years back, I used to put a bulldog and make sure that the vascularity is preserved. Now that is not possible, or it is possible, but not in newborns when you are doing laparoscopy surgery. So sometimes what we have done, we have corrected the volvulus completely, and by pulling the bowel like what I showed you, and then some part of the mesentery or adhesions which are left, you can make out whether it is containing any vessels or not. Because of the presentation was for 20 minutes, I did not show that video, but that is there on YouTube, or in fact, I have more than 100 videos on different kind of surgeries on my YouTube channel. One can go and have look. I call it as a safety maneuver in malrotation, by which you divide the bands at the end of the surgery, or rather after correcting the volvulus. Yeah.
Thank you. Thank you, sir.
Professor Rasiklal, I am sure that you are looking to move to a airport for the flight. I request you leave on time so that they beating the Bombay traffic. And thank you for joining us. And on behalf of the President, President Mida, would you like to tell anything before we sign off, Professor Rasiksha?
Thank you, Professor Shah. It was really a learning thing for all of us. As you said, that it can present in adults also.
Yeah.
Sometimes we do come across not extensive adhesions, but something like that as present as acute intestinal or sometimes as subacute intestinal obstructions also.
Yeah.
So thank you very much for sharing the deeper aspects of this subject. Thank you. Wish you a safe journey.
Thank you. Thank you, sir.
Goodbye, sir. With the permission, we move on. Dr. Ishwar, sir, can you take up the remaining part of the moderation, sir, please?
Yeah. Thank you, Kanahavel. After the first interesting talk on the malrotation, let us go to Sanjay Gandhi.
Have we lost his voice? I think
Pearls of wisdom in managing the choledochal cyst. So it will be wonderful to listen to him, and he has a very vibrant academic career with lots of awards, poster prizes, certifications, and is very, very glad to have him on the IAGES folder here, along with our all the viewers from the ALSGBI and across the continent. Over to Professor Ankur Manchelia for your presentation on choledochal cyst, which we as a surgeon also sometimes get confused how to manage the present late, sometimes even mismanaged. So I like to hear from you how to make a diagnosis, how you manage them, and what group of people manage medically, and what surgery is more definitive, the current guidelines. Over to you.
Thank you so much, sir, for that kind introduction. At the outset, I would like to thank IAGES and ALSGBI for giving me this opportunity. It's a huge honor and privilege to speak to this august audience. I bring greetings not only from Sanjay Gandhi PGI Lucknow, but also from Indian Association of Pediatric Surgeons and its subchapter Pediatric Endoscopic Surgeons of India, of which I am the secretary at present. And I will today share some of our experience of the minimally invasive treatment for choledochal cysts in children, both laparoscopic and robotic. I have no disclosures. The mainstay of treatment of choledochal cyst or congenital biliary dilatation, as it's known, is the complete resection of the extrahepatic cyst with the bilioenteric anastomosis, performed traditionally as a Roux-en-Y hepaticojejunostomy, but also more recently as a hepaticoduodenostomy. Whatever I will be talking today will be about Roux-en-Y hepaticojejunostomy, because that is what we have been practicing for many, many years. So that is our practice, and I will not get into the debate of hepaticojejunostomy versus hepaticoduodenostomy at present due to the lack of time. Traditionally, this was performed as an open procedure. About 30 years back, Ferrello et al. Performed the first laparoscopic repair of choledochal cyst in a child. And it was in 2006 that Wu et al. Reported the first robotic choledochal cyst repair in a 5-year-old child. And then this has been taken up the world over. So I will not go into the details of pathogenesis and presentation. I think most of even the gastrointestinal surgeons and adult general surgeons, they deal with choledochal cysts quite often. So I will go straight to the technical pearls and the tips and tricks for managing this condition with laparoscopy or robotics in children. So how we manage these children are, they are usually scheduled at least 6 weeks after the last episodes of cholangitis or pancreatitis. That is a cooling off period, so that there is not much of pericholedochal inflammation and fibrosis and adhesions. As a routine pre-op diagnostic protocol, we do a liver function test in all children with an ultrasonography and an MRCP in all children. I will reiterate that the MRCP should be looked at very carefully, as there are very often biliary ductal malformations, and the biliary and pancreatic ductal anatomy should be carefully studied and also discussed with the radiologist, especially any variations. Also look for the pancreatobiliary malunion or the long common channel, and we will see how these variations present in some of the case capsules which I will present. Some of the children have very severe cholangitis or pancreatitis that does not respond to the conservative management. And in these select group of children, you may need a pre-op ERCP and biliary stenting to resolve the cholangitis or pancreatitis. But that's a very small select group of children. How do we select whether we want to do a laparoscopy or a robotic procedure? For those who are starting out, there are various characteristics, patient characteristics, which you can take into account, such as age of the patient and weight of the patient. Our youngest child who underwent a robotic choledochal cyst excision was about 6 months of age. But don't have a criteria for the age or weight for selecting laparoscopy versus robotics. Also, you may have a criteria for the anatomy. Our criteria is usually the more difficult cases go for the robotic excision, as it gives a few advantages, which we will see in the subsequent slides. Sometimes the ERCP and stenting does make the surgery more difficult. So we would like to post these children on the robotic platform. Perforated choledochal cysts are usually an emergency, and sometimes the patients are very sick and may not be fit for laparoscopy or robotic approach, and you may do an open procedure. You also have to figure in the surgeon's experience and preference when you select laparoscopy versus robotic. Parental request, sometimes the parents request specifically for robotic procedure. I work in a government institute where we have a fixed slot in the week for the robotic platform. So you have to see whether the operating room slot is available if you want to plan a robotic procedure. and also the availability of finances with the parents, as the robotic procedure is a bit more expensive than the laparoscopic procedure. So going straight to the patient and port positions for a laparoscopic HJ, this is an infant who is placed at the end of the table. The surgeon stands at the end of the table with the camera assistant on the surgeon's right and the second assistant on the left. This is a bigger child, which we like to place in a French position. Again, the surgeon standing between the legs of the patient and facing the laparoscopy screen. This is a Karl Storz 4K system, which on which we do our laparoscopic surgery. These are the laparoscopic port positions. Usually we place a 10 or 12 port at the umbilicus for the camera. This also in smaller children is used for the extracorporeal jejunostomy. The right and left hand working ports are placed in a baseball field configuration, triangulated at the hepatic hilum, and also a fourth port for assistance in retraction in the anterior axillary line. In smaller children, you may use a 3 instrument set for the laparoscopy. In older children, we usually use the 5 set. These are the robotic port positions. If you see, the robotic working ports are the 2, 3, 4. The 3 is the camera port, and as against the laparoscopy ports, the working arms are in a straight line, and usually the company says about 8 to 10 centimeter distance from the target organ and about 6 to 8 centimeters between the arms. However, this is sometimes difficult in an infant, so even if you achieve 4 to 6 centimeter of separation between the arms, it's fine. So this is in a patient where these are the 4 robotic ports. The 4th port again is in the anterior axillary line for the 4th robotic arm for retraction, etc. Also, there is a 5th port, which is the assistant port for the bedside assistant in robotics for passing on the sutures, suctioning, etc. So we operate on the Da Vinci Xi robotic system. It is docked on the right shoulder of the patient. We have a dual console. This is a picture from our operation theater. It's a fairly large operating room. And if again I reiterate the port positions, comparing the laparoscopic HJ port positions on the left and the robotic positions on the right. These laparoscopic port positions are more in the classical baseball field configuration as against the robotic ports, which are in a straight line. A word about ICG fluorescence imaging, which has come up in a big way in the recent times for hepatobiliary surgery. It allows you to do the biliary mapping, allows safe biliary dissection and reconstruction. We use it both for our laparoscopic and robotic surgery. Usually for visualizing the ductal anatomy, you have to give the ICG about 16 to 18 hours before the surgery in a dose of 0.2 to 0.5 mg per kg. In the Da Vinci Xi, there is a Firefly system which is inbuilt. On the laparoscopy system, there are various like the Karl Storz Rubina, etc., which you can use for using the fluorescence imaging. So coming to the surgical technique, I will show you few index cases. This is a 6-month-old infant weighing about 6 kilograms. He presented to us with jaundice, pale stool, and fever, had a large palpable abdominal lump. MRCP showed a huge choledochal cyst, type 1 cystic variety with an 11 centimeter diameter with upstream dilatation. We initially managed the child conservatively with antibiotics and cholerytics, and this was followed after 6 weeks for the surgery. So you see here on entry, there is a huge cystic lesion, so we can't place other ports. So we aspirate about 500 ml of bile from the choledochal cyst directly under vision. This gives us space, and we place falciform hitch and the gallbladder hitch early to retract the liver. The Callet's triangle is then dissected, and the cystic artery and duct are clipped and divided. Then we start dissecting the choledochal cyst medially and posteriorly from the hepatic artery and the portal vein. In this case, there was an accessory hepatic artery. In such large infantile choledochal cyst, it is easier to go around the common hepatic duct first. Here we are separating it from the right hepatic artery, and we have made the plane between the CHD and the right hepatic artery and the portal vein. We divide the CHD-CBD junction, and now the choledochal cyst is dissected from the pancreas and the portal vein and the hepatic artery. Here we again see the accessory hepatic artery going on the surface of the choledochal cyst, which is carefully preserved. We then dissect inferiorly into the pancreas. This is the accessory hepatic artery and the common hepatic artery. We dissect inferiorly till you see the tapering of the common bile duct. Once you see this tapering, the lower CBD is clipped and it is divided. The choledochal cyst specimen is then removed. We freshen the margin of the common hepatic duct and it is ready for the hepatico-jejunostomy. This is the accessory hepatic artery which was present in this case and was preserved. You identify the DJ and mark the site for the jejunostomy. You divide the mesentery. We usually fire an endo-GIS stapler and create the limb and then mark the site for the jejunostomy, which will be done later after the hepatico-jejunostomy. The limb is taken in the supracholic compartment and to the hepatic hilum. The limb is opened. And then we do hepatico-jejunostomy starting from the left corner. We usually use PDS 5.0 or 6.0 in small babies. All our suturing is usually interrupted both on the posterior layer and anterior layer. You need good skills to suture in this area, as usually the liver is moving with respiration and the space is limited. You need to take good bites both on the common hepatic duct and the bubble, and place sutures at regular intervals to prevent post-op bile leak. And usually the hepatico-jejunostomy part takes about an hour, and this is the completed hepatico-jejunostomy. You remove the gallbladder, and also liver biopsy is done. As you can see, there was some nodularity in the liver in this infant. Then the marked JJ site is taken out through the umbilical port, and the JJ is completed and put back into the abdomen. This is the index case for a robotic hepatico-jejunostomy. This is a 6-year-old girl who presented with recurrent episodes of pancreatitis for 2 years, had also transient jaundice. We see the MRCP, and interestingly, we see the right posterior sectoral duct is actually traversing here behind the cystic duct and is joining very low into the common bile duct, which is an unclassified anomaly or the type 7 anomaly. So again, the surgery starts by taking the falciform hitch and the gallbladder hitch. This actually frees up your fourth arm, which can help you in retraction, etc. We start dissecting the Callet's triangle, use ICG. You can see the fluorescence here, and we can see the dilated common hepatic duct and the bile duct and the cystic duct, but we cannot see the aberrant right posterior sectoral duct. We start the posteromedial dissection from the portal vein. The main portal vein comes into view. And the critical step here in choledochal cyst surgery is to circumferentially dissect the CBD from the portal vein, and this is completed here. And then you dissect inferiorly into the pancreas. Again, we use the ICG fluorescence imaging, and still the aberrant duct cannot be seen. The lower CBD is clipped and divided. We open the CBD, and here we see two openings. So one is the CBD and one is the aberrant duct as corresponding to this MRCP. This we stent with Foley's catheter. We start dissecting cranially, clip and divide the cystic artery. The ducts are laid open. So for trainees, it's very important that in such cases, you open the common bile duct from below upwards, open it below the opening of the cystic duct. And here we can see the cystic duct opening, the common hepatic duct opening, and the aberrant duct, which is running behind these ducts and which has this stent. So we divide the common hepatic duct at the appropriate level for the HJ. And now we see that we have now, we also divide the cystic duct. And we see that now we have completely dissected the aberrant right posterior sectoral duct, which was traversing behind. And at this point, we remove the stent and also divide the right posterior sectoral duct at this level. So now we have two ducts, the right posterior sectoral duct and the common hepatic duct, which is formed by the right anterior sectoral duct and the left hepatic duct. So when the two ducts are close together, you should do ductoplasty. Here we are doing a ductoplasty with interrupted stitches. Join the two ducts together with absorbable sutures, and you can do a single ostia HJ. If the ducts are widely separated, you can do a double ostia hepatico-jejunostomy, though it is technically more challenging and may result in stricture if the duct is really small. The rest of the steps are similar. You identify the DJ, fire a stapler to create the limb, mark the site of the jejunostomy. This was a bigger girl, so we have done the jejunostomy intracorporeal with the endo-GIS stapler. You close the opening for the stapler with intracorporeal suturing. The suturing, if you see, is much easier, much more smooth in the robotic platform. It has all the advantages of that 7 degrees of freedom, tremor filtration, fantastic 3D vision, etc., stability of the platform. Again, the hepatic jejunostomy starts from the left corner, interrupted stitches on both posterior wall and the anterior wall. It's important to incorporate both the ducts well so that there is no post-op bile leak. And this is the completed hepatic jejunostomy, and the patient did well post-operatively. Our post-op protocol for both laparoscopy and robotic is to feed the children clear liquids on post-op day 1 and then progress from liquid diet to semi-solids and solids by day 4. Pain management is by a PCA pump. Drains are, we usually place drains in all children as a single subhepatic drain. It is usually removed on post-op day 3 or 4 once the drain output is minimal. They are usually discharged by day 4 or 5 once they're on full feeds and pain-free. We usually follow them up first at 3 months with a post-op LFT, ultrasound, and scintigraphy to see clearance from the liver and see that there is no hold-up and stricture developing. Then follow them 6 monthly for 2 years and annually thereafter. What are the challenging cases? The challenging cases are the ones, as I just showed you, a large choledochal cyst in an infant. There, I showed you, you can decompress it and you can go around the common hepatic duct first rather than going around the choledochal cyst. Biliary ductal variations, as I just showed in the robotic case, these are challenging. You should use both ICG imaging and also, if needed, perioperative cholangiography to delineate the duct. Others are the vascular anatomy variations. I will show you a couple of cases of the vascular anatomy variations. As I showed, some of these cases with this stent in C2 have a lot of inflammation around, and usually the pediatric stent is not available. These stents are usually large for these children and cause a lot of inflammation. So these are the challenging cases, and also the perforated choledochal cyst, as I mentioned earlier. So just mention about the variations in vascular anatomy. If you see, this is the typical type 1 anatomy where the common hepatic artery divides into the GDA and the right and left hepatic artery. But what is very important is the type 2 and type 3 where the right hepatic the type 3 and type 4 where the right hepatic artery actually is replaced and arises from the SMA as this runs right behind your choledochal cyst, and you can injure it or ligate it. Also important is the anteriorly crossing right hepatic artery, which we encounter very frequently. So this is a case of anteriorly crossing right hepatic artery. So on entry, you will usually see a pulsation right at the hilum. The cystic artery is short, so be very careful when dissecting the Callet's triangle in such cases, especially for trainees. Don't mistake the cystic artery for the right hepatic artery and vice versa. This was a replaced right hepatic artery which was crossing anterior to the common hepatic duct. And if it crosses anterior right on your hepaticojejunostomy, there are reports which say there can be an edge stricture. So our practice is usually to dissect the vessel and transpose the common hepatic duct anterior to the vessel and do the hepaticojejunostomy anterior to the crossing vessel. There is literature to say that this reduces the chances of stricture formation, but do it very carefully. Use a vascular loop and do it if you have enough experience with doing this. So now the CHD is anterior and we have done the HJ anterior to the crossing vessel. So this is another example. This is again a type 1 choledochal cyst. You see the main portal vein dissection from the choledochal cyst, but you see a structure pulsating right on the right border of the main portal vein, which should not be there. There's a longitudinal structure on the right border of the main portal vein, which is pulsating. So this is actually a replaced right hepatic artery, which we have identified early. So the rest of the dissection proceeds in the same way, but you have to be very careful of this right hepatic artery, which is replaced and is running right behind your choledochal cyst. You can injure it or you can ligate it in some cases. As we show here, this is a case of robotic choledochal cyst. We have dissected it from the main portal vein, but you see this pulsation. We have actually looped it with the duct, and fortunately, we identified this pulsation and then separated the right hepatic artery from the CBD. So it's very important to identify this variation. This is another case where after the dissection, you see this replaced right hepatic artery, main portal vein, and the left hepatic artery. It's running absolutely on the posterior border of your choledochal cyst. And if you see, there is no right hepatic artery in its usual location. So this is a replaced right hepatic artery. Very important to identify it early. I'll just show this last video where you see the advantage of robotic platform versus the laparoscopic platform. This is a type 1 choledochal cyst. You dissect it till the lower end, till the pancreas, clip it and divide it. The surgery is going smoothly. The main portal vein, again, a replaced right hepatic artery. We are dissecting it smoothly. We have dissected the Callet's triangle. The cyst is completely dissected. And now we are just dividing some structures in the Callet's triangle. And you see there is a huge hemorrhage, which we think is an arterial spurter from the right hepatic artery. It smudges your camera, obscures your vision. In laparoscopy, you might have to convert in such cases if you lose vision. But in robotic, actually, the camera has two eyes. So even if you smudge one eye, the console surgeon can actually still see the bleeder, which is the case here. The console surgeon can see the bleeder and is able to hold it with a Maryland. You lift up your head and you can freeze this arm and you activate the fourth arm and your bleeder is controlled. You can take a deep breath. Meanwhile, your assistant actually rapidly removes the camera, cleans it. You can, if your head is off, everything is frozen. And as opposed to laparoscopy, where you need a lot of coordination between the camera person and the assistant and the main surgeon. And we see actually it was a small accessory artery from the right hepatic, which we do use bipolar energy and we control it comfortably. This was the accessory, and we also place a clip on it, and it's easily controlled. And the rest of the surgery then proceeds in the same way. This is another case with a type 1 choledochal cyst in a 1.5-year-old child, anteriorly crossing cystic artery. Callet's triangle dissection, cystic duct is clipped and divided. We do the rest of the dissection, proceeds well. Go to the lower end later. We have divided the CHD. This is the lower end in the pancreas. This is a tapered CBD, clipped and divided. So the surgery is proceeding smoothly. We have dissected the choledochal cyst. We are just freshening the common hepatic duct here. The margin is freshened for the hepaticojejunostomy. And we think we have ligated all the vessels, but actually, again, there is a small accessory vessel. We think we have ligated it, but there is a huge spurter. Again, from an accessory cystic artery, it smudges the camera. And you can see, because the video recording is from one of the eyes, it has smudged the eye. But again, the surgeon, due to the vision on the console, in this case, we are again able to hold the bleeder. And rapidly, the same steps, you freeze the arms, remove the telescope, again see that the hemorrhage is controlled. You go in and in this case, activate the fourth arm. This arm is frozen. So that's a big advantage. If you see, this is a big advantage. Such hemorrhage in case of a laparoscopic choledochal cyst would have more often than not resulted in conversion unless you are really experienced. So in this case, we are able to take a figure of 8 and the surgery proceeds smoothly after that, and the child made an uneventful recovery. What the robotic platform does for you, this is a slide from a paper in Pediatric Surgery International, is if you see the ability of performance limit, if this is your conventional laparoscopy, the robotic platform actually shifts the ability on the right. And this is my take that the robotic platform, if you do both advanced laparoscopy and robotic, the robotic platform actually you should reserve it for complex cases as it increases your ability or performance limit, even if you are an advanced laparoscopic surgeon. I will not go into our outcomes, but I will just give you the screenshot of our recent papers. This is the first 50 cases of our robotic hepaticojejunostomy for choledochal cysts. We recently published in the Journal of Robotic Surgery. These two papers, published in Journal of Minimal Access Surgery and the Journal of Indian Association of Pediatric Surgery, is our 50 cases of laparoscopic choledochal cysts. So now we have operated about 120 or 125 cases of choledochal cysts with minimal access with satisfactory outcomes. This is actually Dr. Rasik Shah sir's atlas of minimal access pediatric surgery, in which we have written the chapter for the laparoscopic treatment of choledochal cyst, and another IAPS chapter textbook of pediatric surgery, in which we have written the chapter on choledochal cyst. So all these resources, for those who are interested, can please go and search on PubMed, and you can contact me. I can share these resources with you for further reading, and you can see the outcomes and the complications. Due to lack of time, I can't go into them. Also, if you want to see the entire detailed video of the robotic choledochal cyst, we perform this live robotic choledochal cyst surgery on the LabGuru platform. You can click on this link, you can take a photograph, click on this link, and you can see the entire 5-hour recording on the LabGuru platform. Also on the IAPS Society YouTube channel, we did a live laparoscopic hepaticojejunostomy transmission, and you can see the entire video on this IAPS Society YouTube channel. The complete video is there. So for those who are interested, please go and see these videos. For lack of time, I can't go further into the details and the outcomes. So take-home message, MIS approach, both lap and robotic for choledochal cyst excision with HJ is very safe and effective, even for complex and variant anatomy and in very small children. Limitations of laparoscopic choledochal cyst repair currently is that it is very technically challenging, takes a steep learning curve for learning. The robotic approach may shorten the learning curve and expands the access of MIS approach for choledochal cyst surgery, both in children and adults. However, the robotic approach for children is currently limited by the size of the current robotic hardware and the high cost and availability in a country like ours. Thank you very much again to IAGES and ALSGBI for inviting me. Thank you very much for a patient hearing, and I will like to take any questions. You can check further videos if you are interested on my YouTube channel and also on my LinkedIn channel. Thank you very much.
Thank you. Thank you, Professor Ankur Manchalia. It is really our heartfelt appreciation for an excellent presentation on this very important topic, choledochal cyst. I think you really showed nearly a dozen videos, clips, showing various challenges and tips for all the budding surgeons, and really enjoyed your whole presentation. It was like, it's not a 20 minutes, but it looked like a 2020 cricket match. It was non-stop. Everyone was exceeding the previous one. So really entertaining, and it speaks volumes about our experience, extensive experience in this particular field, especially relevant to the robotic techniques for this choledochal cyst. And we'll keep the floor open for further discussion. And over to Kanagavil. Thank you. Thank you once again, sir.
Thank you. And all good things need to come to an end. And I think we overshot by a few minutes. And I think it is every minute is worth in its quality gold of academics. So I think we call this session a close, and maybe we can hear to the president for his closing comments. And then possibly, and I also will be happy to invite you. The next program is going to be on anastomotic complications. We have Professor Asik Shah also available here. Maybe Ishwar sir, would you like to have the questions in the 1 or 2 questions from the chat box? Maybe Dr. Ankur, do you have experience in hydrogenic ligation of variation of hepatic artery? How do you suggest learning for juniors? Maybe they should watch your YouTube channels. And maybe if you can tell if you have any experience of accidental ligation of vessel and how you came out of it, then we'll
yeah, luckily, sir, we have not ligated the right hepatic artery accidentally, luckily, till now. We are very careful. Our experience of minimal access actually is from a large experience of open surgery a few years back. So we are very careful, and luckily we have not injured. We are very fortunate, and we have a great team. So fortunately, we have not ligated it. But if you ligate it and identify intraop, maybe if you just ligate the right hepatic artery, you can just take your chance. It still is supplied by the right portal vein. So you can take your chance and see. But if you make a portal vein injury, you are in a bigger trouble, and you have to repair it intraop. And if you injure the ducts and you don't identify it, yes, they can cause secondary biliary cirrhosis. They can cause leak. They can cause strictures of those ducts. So as I mentioned, both the ductal anatomy and the vascular anatomy has to be studied in great detail, both preoperatively and intraoperatively. And there is no going around that in hepatobiliary surgery, unfortunately. And you have to be very meticulous about that. And see each and every vessel, see each and every branch of the duct and the vessel. That is my suggestion for the youngsters.
Thank you, Dr. Ankur. And your videos are gem of it. Then I'm sure I'm going to revisit again and again. So every single video is an experience by itself. So thank you for sharing for the combined meeting of the IAGES and ALSGBI.
Any comment?
Yes, sir,
Any
please, sir.
comment you have for choledochal cysts which present in adults? Since we do manage them, but at what age? Many of them don't have symptoms and they come to us.
Yeah, are you asking me, sir? Should I?
Yeah.
Yeah, so adults, you must be seeing them regularly, sir. I think adult anatomy becomes much more difficult because they have more prolonged inflammation and repeated attacks, and also more fat in that area. So we in our hospital operate children till 18 years of age. So usually I find those children between 15 to 18 years of age who are almost like have adult anatomy and have multiple inflammations or an endoscopic stent. Those are the difficult cases for us. And I think as adult surgeons, GI surgeons, you would have the best experience for dealing with them. The younger the child, the anatomy is more clearer. There is less fat. So that way, pediatric surgeons are a bit lucky and fortunate that the anatomy is a bit easier for us sometimes, I feel.
Thank you very much.
Thank you.
Yes.
Shafaq, would you like to tell something?
Yes. A question to Ankur and to Professor Rasik as well. It's about transition of care. So these children undergo these really major operative procedures as children, and you guys are great at looking after them until they are like 18 years of age. But then what happens after that? What is the arrangement for transitioning their care to the adult surgeon? What's the process that's involved over here?
So generally, I mean, we have very good general surgery colleagues. We speak to them and hand over. Now, again, this will be applicable only the patients who needs active care. Majority, 95% plus, once you are done with them, you are done. But some chronic conditions like imperforate anus, Hirschsprungs, where some ongoing problem can be there, then we will speak to our colleagues and then hand over to them. That is general process we follow, at least I follow.
Yes, exactly, sir. So we also, like, if it is a patient operated by us and then comes with a complication at say 21, 22 years of age, say in a choledochal cyst, a hepatolithiasis. So we have excellent GI surgery team. We hand those patients over. But if it is, as Rasik sir said, if it is a congenital condition which needs our input, we manage it as a team, and there is a good transition of care at our hospital. So not much of a problem there.
Yeah,
And
I'll say one more thing. Many of these congenital conditions, they will present at 30, 40. Then they will call us and we help them out. It is
yes,
give and take. Yeah.
Yeah, I think it should be a collaborative effort between the adult GI surgeons and the pediatric surgeons, for in such cases.
Yeah, certainly some of the small bowel volvulus for malrotation and stuff, they do present in adulthood. So yes, I take the point. Thank you for that.
Thank you.
So
Dana, would you like to? No, Dana wanted to tell something. Do you have anything more to tell, Dana?
I just wanted to say many thanks to all the faculty because I think the talks were excellent. So many practical points for both people who deal with children regularly and for those who meet them in adulthood. And I would also like to invite everyone to visit our ALSGBI website. There are many educational events. There are also opportunities to apply for fellowships. So please check our website as well, and I hope to see a lot of people at the annual meeting as well.
And I also invite Graham to kindly speak to us as well. Thank you, Graham. You're still
Please
muted.
unmute yourself, Graham.
Your mic is off.
Hi, there we are. That's better. I'm very, very pleased to have been involved with this this webinar. Greatly informative presentations. I think they were very well delivered to what seems to be an increasing number of participants, which is very encouraging to us all. So once again, thanks to all the speakers and technical support staff. Remember, there are two major events in November. One is another webinar, which is going ahead. Notification will be given to you all. And once again, the annual scientific meeting in Stansted Airport. So once again, a good night to you in India and a good evening in UK. Thank you very much for a very interesting series of talks.
Bye-bye.
Thank you, Graham. And Kanagavel, we cannot wrap up before we thank the back support team. So Jenny and Jeremy, who have worked exceptionally hard with a lot of technical support for us. So thank you to them as well. Thank you.
I think special mention should be given to Dana. She has been always pushing so that everything is done in time. And Kanagwel, as usual, he is the backbone of our team. And thanks everybody who has participated. And thanks all the viewers for being part of this program. Thank you, Doc Plus also. I think we had good attendance and hope we'll have more and more and better programs in years to come. Thank you, everybody. Good night. Good evening.
Thank you. Let us sign off. And I'm happy to share we are a 2,000 viewers strong meeting today. And I wish that we keep surpassing our own records in the upcoming meetings. Thanks so much.
That's it. That is besides YouTube and Facebook.
Of course, sir. Of course. Thank you very much. Good night.
Have a nice
Good night,
weekend.
good evening, and good night, everyone.
Thank you.
Bye-bye.